But now expanding further out from an anatomical perspective, we have the nerve coming in, innervating the muscle. And you have a motor unit that is essentially the axon and all the muscle fibers that it innervates. And that's an all-or-one contraction. So when that neuron gets stimulated, all the fibers that it innervates contracts. Doesn't mean the whole muscle contracts, because there are multiple motor units that are going into a muscle. So therefore, the density of the fiber type will affect the type of contraction that is induced. So in general, you have type 1 fibers that have a less number of motor units, or muscle fibers, because it's going to be a more dexterous contraction. Where when you have a muscle that is innervating a lot of type 2 fibers, it recruits a lot of them. So it's going to, when it stimulates, it's going to induce a large contraction. So you can think of the density as kind of a small fine-tuning muscle, or as a big power muscle. So if I want to jump and really have a big push-off, I want to get a large recruitment from the glutes. So I'm going to fire the type 2 fiber bundles in the glutes and get a big, powerful contraction. But if I want to do a small movement, I'm going to initially just start by firing the type 1 bundles and try and do a more subtle activation pattern. So in general, the nervous system will fire the muscles, the smaller density muscles, to have a smaller contraction, and then we'll start to back it up with larger muscles and larger fibers to create a more powerful contraction. So that's general neural principle. Now when we take an even further step backwards, you have the central nervous system that's kind of controlling the whole system. And what we are seeing is that there's actually a pre-firing and a pre-activation of the type 1 muscle fibers. And we're seeing this not only within a muscle. So if I were to recruit the biceps and I did a subtle contraction, you're going to get type 1 fibers. You can get the smaller density fibers that can contract. If I'm going to do a big powerful contraction, I'm going to get a large grouping of muscles that are going to fire. But in a functional pattern, when I go to move, there seems to be a pre-activation of the muscles that have a higher density of type 1 fibers. And these are going to be the stabilizer muscles. So if I were to do an action of reaching with my arm, in the system there's a pattern pre-firing of the deep muscles, transabs, deep multifidus, that will help to stabilize proximally. And then there's going to be a more global firing of the power muscles, the pects and the deltoids, in order to raise the arm. So we want to think about that that's a pattern that's happening, because that's what we're going to use in our assessment. We want to see, is there a pre-firing happening? We can't tell within the muscle, but we can tell between muscles. Are we getting a firing of certain muscles before other muscles that may reflect a more optimal pattern? So that's the main reason for the physiology review. We want to think about the sliding filament theory. We want to think about what's happening in the different types of contractions. And then we want to think about the overlay of the difference between the type 1 fibers, type 2 fibers, in an overall movement pattern. So when we look at,
I just had a question regarding the type 1 and type 2 muscle fibers. So I noticed that in a lot of workout programs regarding calf workouts, they usually have you do reps that are in the higher rep range, so like 10 and up. So I was wondering why that's the case, because I mean the soleus is type 1, is that correct? And then gastroc is type 2.
Yep.
So is there a certain reason why a lot of programs ask you to do more reps instead of less if your goal is hypertrophy?
Well, and we'll get into dosing to target the different ones. But in general, if you're going to try and design an exercise program that has an area that's layered, so your calf is layered, you have the soleus, that's the deeper muscles, and the gastroc. If you start working in high reps, you're training that part of the body to be able to execute for stability. So you might actually design it because in general you want the calf to have endurance, you want to have good stability through there. So that as you're doing the overall training, your gastroc is going to start to crap out and your soleus is going to be able to keep up. So in general, you can do a functional pattern training that slants towards the soleus, based on the dosing that you're going to do.
Okay.
When you were talking about pre-firing of the stabilizing muscles, right? So when you're in the clinic, is it like obvious? Like can you see when there's a problem, or is it more of like your patient has to tell you that they don't feel?
It's a great question, and that's exactly what we're going to be doing. We're going to take that section by section. Because sometimes you can see it, and you'll see it in the form of a failed movement pattern or a give. Other times you can feel it. You'll feel one muscle fire and then a muscle firing, so you can feel that difference. Other times you can feel, or the patient will feel, when things shear. So like, for example, in the shoulder, if the rotator cuff doesn't pre-fire before we move the extremity, you get that translation that we spoke about in anatomy. You get translation of the humeral head, and then that can induce pain, or you might actually feel the altered movement. So we'll apply all of that. Patient feedback, what we're feeling, and what we're seeing. Okay? And from that, we apply that concept of timing to make a clinical decision about what's going on. So if we can't feel the exact timing, when we see the pattern give, or we see the movement dysfunction, then we're applying that theory, saying most likely there's a delayed timing, that's why this movement pattern is not optimal. All right, so when we're looking at overall muscle performance, we want to think about the difference between strength, power, endurance, and these are definitions. You have to know the definitions. They show up even on the boards. So essentially, you want to think about strength as that ability to exert force one time. You want to think about power as being time dependent. That's key. All right, it's work over time. So power is time dependent. It's the amount of work that you can do in a specific period of time. Now, when would we need power? Who needs power?
Everyone.
You do. We need power all the time. We need power all the time. So who are you going to do power training with? Dave. Definitely do power training with Dave. Are we going to do power training with our elderly patients? Absolutely we are. Because they need power to get from sit to stand.
Yeah, I was just gonna say, sorry, so like power could be like your tolerance of explosive for you.
Exactly.
Like in that version you need to be able to get off the toilet.
Yes.
And you know what I'm saying? I mean,
It's very functional.
guys, we all know someone who's falling off the toilet. So their explosive for them is like you said, it's not necessarily, I'm not gonna be working on jump squats with them, but
Yeah.
they need to be able to have enough force to get from
Exactly. So we want to consider power for everyone because we all need some element of power. But we don't all need huge explosive power. So advanced plyometric training is not appropriate for everyone. But for the athlete, it's very appropriate. So we want to think about the time-dependent contractions and execution as well. Endurance, we're thinking about the ability for the muscle to either maintain over a prolonged period of time or to produce multiple contractions over a period of time. Other things that affect overall muscle performance, the things that can affect strength. And the reason we bring this up is to think about how we're positioning someone for an exercise, but also in your testing. So we remember moment arms, right? Can I borrow you? Lie on your left side. So how does a moment arm affect functional strength? That's around. What is a moment arm? It's the lever. It's the perpendicular distance from the axis of motion to the force being applied. And this very much comes, and it defines the lever. So if I were to do a hip abduction manual muscle test, hold right there for me, and I were to stabilize and then push here, what kind of moment arm am I utilizing compared to if I push way out here? A short moment arm, rest. So my distance from the axis of motion is shorter here, therefore the ultimate torque that I'm inducing to the hip is less because there's a shorter moment arm. And I have to work harder if I want to really get that break, as in the manual muscle test. If I go way out here, now I'm able to induce more torque because I have a larger lever arm. Okay? So if I do the manual muscle test, I can push here with 2 fingers and get the break. Well, maybe not never, but sometimes. Now, that's important in doing your manual muscle testing, but it's very important when you're defining an exercise. Because if you write down and you say someone can do hip abduction at 5 pounds, and you're putting the weight here, and they're performing hip abduction with the weight here, just go up and down a couple times. And then someone comes in and says, okay, we're doing hip abduction 5 pounds, and they put the weight over here, that's going to be a very different experience to the patient. Okay? So you want to keep that in mind when you're applying your manual resistance or your manual muscle test, but also when you're setting up the resistance for the patient. Okay? So that's why lever arms and moment arms are important. The other thing that can affect the overall functional strength is the alignment. So when we look at the hip, what muscles on the lateral side of the hip can produce abduction? Glute med, what else? TFL. So if I'm trying to target glute med, because that is one of the deeper muscles of the hip for stabilizing, what position do I want to set this person up so that we can target glute med? Slide extension. Now why did it soften the knee? Why do we want to set up in slide extension? Because TFL turns on during flexion. Why? Because it knows that we're flexed?
Alignment.
Line of pull. And it's the alignment of what? The fibers of the muscle. So when I bring into hip extension, we have the glute med. We're lining up most of the fibers of the glute med as it converges on the greater trochanter. So now, if the muscle contracts, and I'm going to let go, hold your leg there, the muscle that's best aligned to support the leg or perform the abduction and rest is the glute med. So I've set up the alignment to best target the glute med. Furthermore, I've placed the TFL at a disadvantage because the fiber alignment of the TFL would love the hip to be in flexion. So if the hip is in flexion, and now, go ahead and AV duct. As your patient AV ducts, the TFL is recruiting more because it has a better line of pull. So if our goal is to train glute med, we want to set our patient up in the best alignment to target glute med. So alignment is hugely important for our exercise. How else can we use alignment to determine if a person is performing abduction with the muscle that we want versus a muscle that we don't want? How can we reverse this concept? So in assessment, try and figure out what's going on. Just ask them to do it. Go ahead and lift your leg. And if the patient lifts their leg and they pull into hip flexion, what are your thoughts? TFL. Because the body, the movement deviated to better set up the muscle that was stronger. So if we say, go ahead and do your abduction, and the person goes into flexion, we call that a give, deviation, or compensation, because a person cannot perform that movement with our desired muscle. Thank you. So we can use alignment to set up the exercise, to target the muscle we want. But we could use deviation from a proper alignment as an example of when a movement pattern is not going the right way, when a muscle is kicking in to compensate.
My favorite thing to do during eval is bring that into that position though, and say, okay, it's right here, don't move at all, and then like go and see which muscle they prefer to use. Sometimes if I bring them to extension, they're going to move to flexion, set up into extension.
Perfect. So that's a perfect example where you can palpate to feel which muscle's going on. But if you set them up and they're not able to maintain it, you see that give deviation, and now you theorize that they're recruiting the wrong muscle. Okay? So that's a great strategy. So, there you go. In order to have good functional strength, it is the interaction between the muscle, the neurology, the biomechanics, and psychology. So if someone doesn't have the motivation, they're not going to exert well. That factors into it. If someone doesn't have the muscle hypertrophy, then that's going to factor into it. If someone doesn't have the recruitment of the nervous system, that's going to factor into it. If someone has altered biomechanics, so they have a malalignment, they have a rotated segment, they have a sheared humeral head. That's going to affect your overall exertion, your functional strength. So as we mentioned before, we want to target the thing that where the patient's biggest need is. If the biggest issue is the altered biomechanics, do a biomechanical correction. If the biggest issue is atrophy, do hypertrophy training. If the biggest issue is poor nervous system coordination, do coordination training. Okay? Now, the types of contractions, I did this a little bit out of order. So we see that this is really where I meant to do concentric, eccentric, and isometric. So we have the definitions here so you can review the different concepts. Keeping in mind that a concentric contraction is your shortening contraction. The isometric is a holding contraction where there's no change in length. And an eccentric contraction, whoops, still in the wrong spot. Gotta flip that whole thing. There we go. And the eccentric contraction is the lengthening contraction. So these are important concepts, one from a definitional standpoint, but also in defining your exercise. From that concept of the different types of contractions, you can utilize different exercises that take advantage of that. You can do an isometric exercise where it's a holding contraction. You can utilize isometric contraction and exercises early on in rehab. You could also utilize it to try and target the stabilizers. And we'll see that when we're doing some of our stability assessment, we'll utilize isometric contractions. You can use concentric and eccentric to test the muscle's ability to move through range and to test the strength through range. Another form of exercise is called isokinetic. Iso meaning same, kinetic meaning movement. So it's essentially the same speed of movement. So for an isokinetic exercise, which has gone out of favor, but you still may run into it, you need a piece of equipment that's going to maintain a certain speed. And this was utilized in sports rehab years ago, because essentially you could have the person try and move as fast as they possibly could. They're all strapped in, they're doing knee recovery rehab, they're trying to do reversals as fast as they possibly can, and it's a safer way to doing it with the isokinetic machine because it's controlling the speed. They can't get the whipping motion because the faster they move, the more resistance they get from the machine. So they're having to maintain a certain level of speed while they're doing that. If you don't have an isokinetic machine, you're trying to do it with weights, the isotonic type resistance, then when you try and do the reversal, you get a shearing action, you get a whipping motion. So trying to do speed training with ankle weights or on a Nautilus, it sets you up for shearing. So that's why the isokinetics were so big for a while. It's fallen out of favor because it's fairly cumbersome to try and set someone up on it, but it's a very interesting workout when you use an isokinetic machine. So those are different types of contractions. We looked at the physiology and we looked at some of the different types of exercises that you could utilize for someone. What you need to do is think about what the different function of different muscles are. And you've had these definitions, so you want to frame them in an exercise sense. And the reason you want to think about them is, one, because of how you're going to progress functional exercise, but also you want to start to think about what sort of things can limit emotion. So if we're going to produce emotion, the main muscle that generates that motion is called what? Is your agonist. So the muscle that's said to resist that motion is called antagonist. Now that's important because if you're going to do a strengthening, a flexion strengthening, and you lift, you want to think about which muscles are your agonists. These are your target muscles. These are the muscles that you're strengthening. However, if you cannot complete the motion, you also want to think about the muscles on the other side that might be resisting that motion. And that would be the antagonist. So if you have a short or stiff antagonist, when you try and do a motion, you're not going to be able to complete the motion. And you're going to have to define which muscle it is. So in your chart, when you're building the chart, you're defining the different movements, shoulder flexion, and you're going to define which muscles are the agonists. But you're also going to define which muscles are the antagonists that may be disrupting things. The other reason that you need to consider agonists versus antagonists is you get co-contractions for stability. The muscles on either side come in to stabilize an area. So you want to keep in mind which muscles are the antagonists because you may actually need to train them for stability training. The other reason to consider it is that all of our movements are actually controlled. We talk about agonist as doing the motion as if the antagonist fully relaxes and is totally passive. But it's not the case. The agonist will actually come in to help control. So what you'll actually get, especially in higher speeds or in functional movements, the agonist will produce the motion, but your antagonist will come in and perform an eccentric lengthening contraction to help to control the motion. So there will be times that you're going to train the agonist, but there will be other times that you're going to eccentrically train the antagonist so that you can train the coordination of both muscles on either side of the joint. The other terminology that you need to keep in mind is the idea of a stabilizer. So the stabilizers, mainly we're talking about the proximal stabilizers, and synergists. Now, synergist can be a muscle that helps to produce the motion, or it can be a muscle that comes in to neutralize motion. Okay? So let's take the elbow, because the elbow is a good example. If we were to contract and go through elbow flexion, what is the main agonist for contraction? Biceps. Okay? So who's going to help them out? Brachialis. So we can say that biceps and brachialis are synergists. So the brachialis, the biceps brachii does elbow flexion, as we just cited, but what other motion does it do?
Supination.
Supination. So if the biceps were to contract, essentially you would flex the elbow and you would supinate. So let's say you don't want to do that. Let's say you want to pick up that nice glass of beer and you want to bring it to your mouth, and if you go to take a sip and you all of a sudden do that, that's not so convenient. So what would you do? Come up with a strategy. How am I going to stop that from happening? I'm going to fire my pronators. Am I firing the pronators so that I dump my beer this way? No. I'm firing the pronators to neutralize the supination. So I'm still able to use the biceps to bring the cup up, but I don't want the supination, so I'm utilizing the pronator to neutralize that motion. Okay? So it's still working in synergy. It's coming together to perform that coordinated movement pattern, but it's not helping the flexion. It's helping to neutralize an undesired motion. Now this concept is important because when we're looking at movement patterns, we want to see what's failing. Maybe the reason that someone is dropping into ankle inversion every time they push off is because they're not neutralizing inversion. And what muscle would neutralize inversion? An everter. So we need the strength, power, and coordination of the everter to be able to stop that collapse when I push off. Okay? And that's one of the things that we will be looking at. So we mentioned about fiber type. Fiber diameter also affects the overall speed of the contraction, and that's going to relate to the fiber type. Type 1 fibers tend to have a smaller diameter, therefore a lower force production. Type 2 fibers have a larger diameter, so they are able to recruit more fibers in their contraction, so a more powerful contraction, and it tends to be faster. But there are other things that can affect the contraction of a muscle. And this is where we want to have a discussion on the length-tension relationship. In manual muscle test, what position did you place the person in order to perform your brake test? That's true. Let's not do one joint versus two joint. In general, what position did you place the muscle in to perform your brake test? So you did two types of strength testing, right? Okay. So what were the two positions that you did your strength testing in? So that can change. So we're not going to do against gravity or with gravity yet. But what's the range change that you guys did? Mid-range, or what do you mean by end range? Fully shortened. So the fully shortened position is called the inner range. Right, because it's the inner range of the movement possibility. So if you did the resistance testing in inner range, and you did the resistance testing in mid-range, for the same muscle, which one showed up stronger? All right, turn to your partner.
Hello again.
Bicep testing. You're gonna put the elbow in full flexion and say, don't let me straighten the elbow. Then put the elbow at about 90 degrees. Put it down, lower your arm, lower your arm. Say, don't let me straighten the elbow. Okay? Do that on each other. Let me know which one is harder for you to break. In which position? No, don't go up there. Oh, I see. That's all right. Forget that. We have other ones that are two joints that you ordered three.
Okay, ready?
I'm just voting on.
Don't let me punch
Okay, 90. Hey, honestly, you're strong in both. It was easier for me to break like the mid-range. You're so smart. I hate you. Oh, yes, yes, yes.
Alright, what'd you guys find?
Mid-range.
How many people say mid-range was harder to break? How many people said the inner range was harder to break? How many people didn't vote? Yeah, you gotta have a vote. How many people felt it was exactly the same? Okay, so there was that. That was the third option. I forgot about that. All right. Yeah.
Does part of it have to do with leverage? Because it's easier to pull this way than to like.
So leverage will play into it. So that can play into it some. But either way, you should be able to get a break and get a sense of, did you need to utilize leverage in one case versus the other? So you can figure that overall out. Yep.
Is it, technically fully contracted if you go to mid-range?
Is what fully contracted?
Like your muscle that you're isolating? To try and test.
What do you mean by that?
So, like, if, like this would be like fully contracted, but what about since like mid-range like here?
Well, again, what do you mean by fully contracted?
I don't know.
Like the muscle.
Your question.
Completely shortened.
Completely shortened. So how would that possibly affect contraction?
Well, it wouldn't go, if it's fully shortened, it can't shorten anymore.
That's true, but we're not getting into active insufficiency.
Oh.
Okay. But what are we discussing?
Myosin cross bridges.
Myosin cross bridges. So if the filaments are out here, and we perform a contraction, and the myosin heads contract, if I'm way out here, I need ground substance to hold for me. If there are myosin heads here, can the myosin head here help the contraction?
No.
No. Can the myosin head here help the contraction?
Yes.
Sure. So when this one contracts, it starts to slide it in. So what happens as they come closer together? The other guys can start, don't overlap yet, we didn't overlap yet. But the other guys can come in. So there are more that can help. All right, so let's do, imagine this one's here. Ground substance. So put your hands up. Okay, you stay over.
I'm really
no,
short.
don't grab, don't grab.
No?
Stay over there. Yeah, lower a little bit, don't make it work too hard. Okay. All right, so how many, this is ground substance, how many myosin heads can help in this contraction right now? One. All right, can these two help? No. What is this position for the muscle? Lengthen. It's in its longest position. So now, let's start to shorten the muscle. So this myosin head can grab. It grabs, it pulls it in. Then this one grabs, and this one grabs. And we get right here. Now, how many myosin heads can help the contraction? All of them. A lot of them. So over there, I know I threw a couple extra here. So what would this right here optimizes the ability for cross bridging. Okay? Now what happens if we keep going? No, stay up there. Stay up there. I'm simulating cross bridging. So as it starts to slide in, you start to get bunching, and you don't get effective cross bridge because now the filaments have slid too close together. Thank you. So the theory of sliding filament theory says that your greatest contraction will happen when you can get the greatest number of cross bridges. And considering the visual of the filaments that slide all the way out here and the filaments that can slide all the way in here, what position are you going to be able to create the best number of cross bridges?
Mid-range.
Mid-range. And this helps us to define the length tension curve. Because if we do the testing, now part of the variation in finding, it has to do with the lever arm. It also has to do with you have multiple muscles that are doing elbow flexion, so you have two joint muscles. So there are a lot of things that factor into it. But this does highlight the reason for why, when you're performing a break test, you want to get right to the verge of a break. If you don't actually get the break, you're not fully testing that muscle. So then you can get a false reading. So the length tension curve essentially talks about the inner range into the lengthen range. So this is the shortened position for the muscle, and this is the lengthened position for the muscle. So your optimum number of cross bridges is going to be right in that mid-range. When you go into the shortened range, you get that overlap. So you're not able to establish the cross bridges. When you're in the lengthened position, the filaments are too far apart, so you can't access some of the myosin heads. So when they do strength testing throughout the range, this is exactly what they see. They see that it's a little weaker here. As they go to mid-range, you're able to generate more force. And as you get out here, you're able to generate less force. That's your length tension curve.
And does that go back to the lever arm that all kind of ties back in?
No,
It's
so
a
the,
little separate, or that's different.
so the difference is the ability for the muscle to generate force versus functional strength. So the length tension relationship of the glute med is going to be the length tension relationship of the glute med. All right. So if you keep the lever arm exactly the same, you will be able to define the length tension curve of the glute med. But it doesn't necessarily define its functional strength, because its functional strength is being affected by many factors. Alignment is one of them. We saw that. But the other possibility is the lever arm. So if you change the lever arm, my leg, let's say, if I were to push with my thigh, let's say I push out and I can move 100 pounds with my glute med. If I put it all the way down here and I try and move that same 100 pounds, I might not be able to move it because now the weight has a longer lever arm. It's harder for me to get that weight out there. Okay? So that is the idea of functional strength. How much can I kick a 100-pound weight away from me? Now the idea of functional strength plays into function and rehab in a big way. And this length tension curve can be affected by that. Now, I said the word inner range, and I know that's a new term for you guys. Inner range equals the shortened range of a muscle. So what's the inner range of the biceps? Here. Okay? So when the elbow flexors contract, the elbow flexes, and we're trying to make the contraction happen all the way to its inner range. I can do some resistance testing there. But that's now assessing its inner range. This is the mid-range. Out here is the muscle in a lengthened position, so that's its lengthened range. Another term for lengthened range is outer range. Okay?
Is inner range synonymous with end range, or is it the opposite?
So that's why I was asking for a clarification of what we meant by end range. Because you have an end range in both directions. I have end range flexion and I have end range extension. So end range flexion is inner range for the bicep. But it's outer range for what? Tricep. Okay? So when you say end range, you're kind of talking about a joint. When you say shorten range, lengthen range, when you say inner range, outer range, you're talking about the position of a muscle. Okay? Okay. So now what you're seeing here in this center line is a length tension curve. Okay? Here is its maximal strength. And I know the manual muscle test position is here. So we'll say this is close to its mid-range. And we're applying the manual muscle test here. This is where we're testing the biceps. When we test it here in the inner range, it tests a little weaker. When I test here, it tests stronger. If I go all the way out into its full length and range, it tests weaker again. Not as many cross bridges, Somewhere around here is maximal cross bridging, and here I'm getting overlap, so I can't optimize my cross bridging. Everyone okay with that? Functionally, our alignment and our muscle length tension curve is set up to optimize efficiency. So for example, let's take the glute med, our glute med example for hip abduction. Right? Does glute med abduct the hip? Is that its main function? How many times throughout the day do you do this? Too much. Right? So if I'm playing soccer, or I'm going to do an activity where I'm going to do that, then yes. But what is glute med's main function? Now I can say it. Pelvic stability. So if I stand on my left leg, what does gravity want my pelvis to do? Drop. This drop of the pelvis is what kind of motion at the left hip?
What are you saying, internal versus external?
No. AD versus AD.
AD.
I'm adducting. Okay? So what muscle is set up well to stop the pelvis from dropping?
Glute med.
My glute med. Okay? So when we step, we want glute med to fire to stop the pelvis from dropping. What point in the length tension curve is this for the glute med? Good. What's its inner range? Tell me to do it with this left leg. Abduct. That's its inner range. What's its outer range?
Adduct.
Abduct. Glute med is lengthened. Glute med is shortened. Therefore, right there is mid-range. So when I step, that's mid-range. Okay? Does that work out in our scenario? So the optimal strength point for the glute med is mid-range. And my biggest need for the glute med is at mid-range. So that matches. Perfect. Right? Everyone follow that? Now, if we habitually use a muscle in the wrong length, or if a muscle inhibits, the neural drive to the muscle tamps down, and that causes the muscle to live in an altered length position. In other words, a lengthened position. The body goes through adaptive changes. Essentially, where the actin and myosin cross bridges occur shifts. If I don't contract my biceps to the inner range, if I only use my biceps here, then the actin and myosin and the inner range gets reabsorbed. Myosin heads get reabsorbed. So that when I try and now contract into the inner range, I don't even have the proteins available to be able to contract into a shortened range. And I will show up with inner range weakness or an inability to get into the inner range. That make sense? If I don't use it, I lose it. If I don't access the myosin heads at the shortened position for any muscle, it starts to get reabsorbed, and I lose them. So now if I start functioning like that, I don't lose all the myosin heads. I'm still strong throughout the rest of the curve, but the inner range is weak. And what happens, hold on, is you ultimately end up with a shifted length tension curve. Where if that muscle is habitually lengthened, if I were to now chart the length tension curve, if I put the joint into this inner range, if I try and put the joint in its end range of a flexion, it can't even contract anymore. So I have to put it here in order to get that light contraction. And what happens is the entire curve shifts to the right, so that its optimal strength position is now further out. And in order to get to the position that I would want it, it has to be all the way out here. Because in my desired position, in my manual muscle test position, my now lengthened muscle is testing down here, which tests weak. If I go throughout the range, I still find some decent strength in that muscle. In other words, the manual muscle test is still there, but it's in a very lengthened position. Okay, can I borrow you again?